So we're going to start out. Here's my nice patient, Pat, who has been my patient for a number of years, who came over from Bradenton so that we could do the Insta-Lift, and then we're going to do some other things. So why don't we start out and tell me what you think there, Sasha?
Sure. So I think this morning we had a chance to kind of tag team a facial assessment. I'm going to run you through what I'm typically looking at if she was coming into the office and she was sitting in the exam chair, what it is if we were doing a true full face assessment, and then I'll run through that, and then I'd love for Dr. Winkle to comment as well. So first and foremost, first thing I'm doing is I'm just going to position her in the appropriate position. She's got looking straight ahead. I'm looking at that Frankfurt horizontal plane. And I'm going to start by really looking at everything I see in the upper third, which I tell patients that they're holding a mirror throughout this process. I think it's very important for them to see what I'm telling them and showing them, because that way they're just not nodding their head and, okay, that sounds great. So I'm looking at hairline to the lateral canthus as my upper third, my lateral canthus to the oral commissure, so as my middle third, and this I'm going to stretch from the oral commissure down all the way to the clavicle. Even though that's more than a third, I'll call the whole neck its own aesthetic subunit. When I start looking at her from the upper third, the first thing that I look for isn't the forehead and irides and creases through there. I like to look at brow position first, because that's telling me a lot about what's going on. And what I'm seeing when I look at her from a brow position standpoint is, first and foremost, is that her left brow sits, again, probably 2 to 3 millimeters higher than her right side at rest. Go and raise your brows for me really high. Good. And I'm going to look. And even when she raises her brow and relax, go ahead and relax for me. Thank you. You can still see that it pulls a little bit higher on that side. I don't know when the last time was that she had neuromodulator. That'd definitely be part of my consultation and discussion with her, as when was the last time she had
last week.
There you go. Perfect. So,
but listen, I only put 10 units up here.
Sure.
Because I would rather see that patient back in 2 weeks, especially if it's a naive patient, and tweak it than wish I hadn't.
Agreed.
And so I think totally we have a little neuromodulator here. We'll put some, but I find that such a slippery slope. I don't want to do that, right? I mean, if I drop that brow too much, so raise your brows again for us. All right, turn to the side. Wait, no, turn this way. I'm so sorry. Turn that way. See that? So we can see this point of maximum pull. And you can see that I wasn't real aggressive with both. She could probably use a little bit more.
Exactly. Yeah.
Not that we don't want her to have some movement, but just a little bit more softening. And here's that place with no muscle, so she probably needs just a drop right here.
Right. And I've gotten into a habit of injecting, even though that's that sort of aponeurotic. You can relax on your forehead. Thank you very much. Her forehead's going to be exhausted by the time we get done.
It's a workout.
So I like to inject a little bit in here because I know some of those fibers may pull. I know theoretically there's not really muscle belly there, but I'm a fan of sometimes injecting a little bit of it through there. But I would agree that the lion's share of what we want to do is going to be a little bit laterally. But again, with her brow position, still though, what I'm seeing is a well-placed and arched brow. The ideal feminine brow sits usually 1 to 2 millimeters above the level of the supraorbital rim, right? And she has a very well-defined supraorbital rim, which we were talking about earlier, and we'll discuss in a little bit. But given that it sits above the supraorbital rim, I know she doesn't have true browtosis. She doesn't have a Mephisto or a spocked brow at all. So she's got a well-positioned brow, and it's not ptotic, and it's sitting right where it needs to, but she has a lot of periorbital hollowing. So I'm using all this as information for me just to kind of get a sense as to what her muscle pull is like and where this brow position is. So that's one of the first things I'm looking at. We already assessed her forehead to look at what her frontalis strain is like. With her in particular, I joke with patients and I say, you got a 4-head. Sometimes you can have a 5-head, a 2-head, or a 3-head. So the fact of the matter is, she does have a 4-head, but she does have some real estate here. So I would work a little bit closer to the hairline just to kind of help, again, relax some of those lines.
Good.
That's part of my upper third. When I start looking in between the eyebrows, bring your eyebrows together. Let me see. Kind of the angry look. Good. Frown.
She's not looking that angry.
Good. She most definitely isn't. And she's going to look even happier after her treatments today. So I'm excited about that. So her corrugator, procerus are all very nicely controlled with her recent neuromodulator injection, which looks great. And then I'm always having them do a big smile for me. Good. Just to look at the lateral kind of orbita in this region to look at what her, and you can relax, to see what her orbicularis oculi is doing in terms of some crow's feet. And so in that standpoint, she might be able to benefit from a touch of, some normal.
She had some neuromodulator here, but these are those zygomatic cheek lines I was referring
Sure.
to. Smile again, please. And see this? We are just not going to relax those completely. Sometimes, if they have a good snap test, I actually will, even not to change the aperture, I will actually come and put a little bit of neuromodulator infraorbitally there just to try to soften these a little bit. I can tell you that many of my patients, everything is looking good, and then they come in and they say, I just hate this.
Mm-hmm.
Well, these days I'm peeling it. That's my newer thing, is to do a little peeling. But I think somewhat of it is patient expectation and realization that we're not trying to be 20.
Right.
Okay? All right. Well, speak for yourself.
Maybe we have to ask her.
Okay.
That's right.
All right.
So that's what I'm looking at from that standpoint. When I start working my way still through the junction of the upper and middle third, I'm looking at the temples, right? So I want to see if she has an overall thin aesthetic, thin ankles, thin wrist. She's taking good care of herself. She's thin face, oval in that capacity. But I'm noticing that she's lost a little bit of volume in through the temples. And so she's pretty well stocked right here laterally to the hairline. So I just noticed a little bit by the junction of her supraorbital rim here again, as we look at the frontal bone making its attachments here at the zygomaticofrontal suture. So that's just kind of in through here that we noticed just a little bit, but that's just being really nitpicky. Altogether, I think she's got pretty good volume in through there. One of the things before I get to the middle third that I noticed in her, more than a lot of other patients, is she has a lot of recessing in through her supraorbital rim on the inside, in through that portion of her orbit. This is definitely a very challenging problem. We've read surgical literature that talks about periorbital fat grafting, these types of treatments. I'm not particularly huge on that. I think that there are some, again, devastating complications that can occur. This is right through those important vessels that we spoke about earlier, the supraorbital, supratrochlear. So what I'm usually doing after I've done everything else is then really taking a look and seeing, can I make this a little bit better? And if I do, it's, again, low G prime, small particle size. We're talking about our Volbella, our Bellatero, maybe a little bit of silk, perhaps even some refine, or maybe even velour in certain instances, where I am basically marching right along the bone in through and around the orbit to give her just a little bit more periorbital filling here. We're not going into this recess at all. She needs to have an appropriate exam to test for ptosis. Perhaps she has some of her levator that's dehisced, and so that's something we would bring the other Dr. Winkle in for and let him take a look, but I would also assess her for ptosis by looking at her what we call marginal reflex distance, or MRD. Bigger picture is a little bit of periorbital filling here could just help take the edge off a very recessed eye socket, so to speak.
And sometimes that eye socket has what's referred to as an A-frame deformity, where it's particularly accentuated just in the slightly medial aspect. Mm-hmm. I actually have that. I haven't ventured to do that to myself. It's a little even too scary for me to do. But I think that little tiny needle injections, very superficially, then taking a Q-tip and molding it down might be helpful.
Yep.
We're actually not going to do that today. I really haven't done that very much, but I feel like that it's something that safely, as long as you're very superficial, and we know those vessels, the depth of where they are, and so again, just like effacing these glabellar creases, we're just going to have to stay very superficial and then blend it down. Some of our colleagues will actually take a cannula and go across just in the infraorbital rim area.
Right, and I won't do that because I don't feel like I have enough control with it, as opposed to, again, if you use something that's very easily moldable, small little depots of 0.1, 0.1, 0.1 can just be nicely massaged out because it's so malleable, and you can just place it right along the bone and just create that contour. Okay. But that is something that I think that, I would be looking at if she was in the office. And that's everything I'm seeing so far from the upper third. As we transition, I would always be looking at the tear trough, and again, periorbital volume there. She really doesn't have much of a tear trough deformity in that capacity. She's thin in through here, but nothing that seems like it needs to be overly filled by any means. Once I start making my way down to the middle third, mid-third of her face, I'm noticing that she's a little bit flat over her zygoma, and she's definitely lost a lot of volume centrally and medially in her superficial and the deeper fat pads in through here. So here, some lift or voluma is really going to give us the ability to start getting take some tension off of her mid-face and starts to bring this up. Could I get you to maybe just rotate a little bit this way so we can just see you in a little bit of a three-quarter profile view? Thank you so much. So again, she doesn't really have much of an OG curve here or maximum point of projection over zygomatical maxillary buttress, whereas that fusion line is here. That's the area that we want to help accentuate, and it would also help with lifting and taking tension off of her nasolabial fold. So these are the types of things I'd be pointing out to the patients and what I'm looking at from a full face assessment. We still haven't made our way all the way down. I'm going to go and rotate you back facing straight. Thank you so much. When I'm looking at her now straight on, we notice that if comparing from the left and right side, her right submalar hollow is more pronounced than the left side, meaning seems to have a little bit more volume in this region. So once I correct her mid-face on both sides, I would also consider some submalar injection and diffusely through here. This becomes almost dealer's choice with the product to use.
Dealer's choice? Mm-hmm. We're coming up with some interesting terminology.
So from that standpoint, we've got our velour, we've got classic Restylane, we've got Refine, we have Define, we have Versa, we have Ultra and Ultra Plus. I mean, you really can actually, as long as you're in the correct plane here, you can really almost do no harm with respect to picking the right product, because you want to use our medium G prime, something that's got some volume. We don't want to put voluma there and overfill here, because then it's going to look, almost chipmunk-like. So we just need, after we do the mid-face correction, come in here and just do some work in through that region as well. So that's what I'm looking at from her. That standpoint, she doesn't really have much of a nasolabial fold. And once again, we correct here, and Dr. Winkle does her Insta-Lift here. We're going to take a lot of tension off that nasolabial fold. We don't need to chase that fold in her at all. But these are just some of the things that I'm noticing. And again, from her, if we're looking at her not her columella, if we're looking at her lips, and we're also taking a look at her filtral columns, she has some flattening across this region from the ergotrid, like you mentioned earlier. So some very finesse work could be done to help accentuate a little bit, because she's just really kind of flattened out a touch in through there. But that'd be after I corrected her lip itself, if we did some work on those lips. And then we start making our way down to the lower third. On the lower third, when I'm looking at her, I'm noticing more volume and more fullness, again, on this left side in comparison to her right side. And we're going to correct a lot of that. I'm going to let Dr. Winkle talk to us about her technique for Insta-Lift. But along that way, once we correct a little bit in through here, I think her mandibular definition is a little bit sort of weak in this posteriorly as we go back towards her mandibular angle. So I would, in addition, once I see where the soft tissue and skin envelope is redraped with your treatment, chasing that with a little bit of filler just to give her some, almost like a little strut for all that skin to rest, on which to rest, could be very nice. And then when I'm looking at her in a lateral view, which we'll show you a little bit in a moment. Actually, could I get you to sneak around one more time for me? Thank you very much.
Yeah, I think maybe she can just turn her head.
Yeah, perfect. Okay. We can see that she's probably a little bit, let me see your bite.
She's got a little chin protrusion,
right?
Yep,
exactly.
We didn't notice that before.
Good. So when I'm looking at her bite, I'm looking at her occlusion, which is actually looking at her premolars. But what I am seeing is she's got a pretty good anatomic bite. So what this means for me, she doesn't have retrognathia, which is often confused with microgenia. Retrognathia is if she actually had an underbite, or her mandible was a little bit retruded, or her maxilla was protruding. That's retrognathia. She has more microgenia, which actually just is a more correctable issue, which means she just has a little
chin.
Exactly. That's right. So for her, somebody like her, we don't need to recommend any type of crazy orthognathic surgery, but what we could do is just correct it with a little bit of chin filler as well. And once the skin and soft tissue envelope redrapes, bringing this forward will also help bring her skin out to length. And that eventually takes us into the submentum. We know we've got some submental fullness a little bit down here, but she does have skin laxity. She has some platysmal bands, so she may not be the right Kybella candidate because we're going to end up skeletonizing that muscle. And so we have to talk to her about whether she's okay with the fact that maybe we'll get a little bit of retraction and get a little bit of volume away from there. But what if those cords become more prominent?
Yeah.
Right? That could be an issue. That
Worse
could be
instead
something.
of better.
Exactly. So we have to have that discussion, conversation. I have pictures of patients who've had some skeletonization. I say, would you be okay with this for the skin getting better? So, and then globally, we would be doing a skincare discussion as well about microneedling and PRP versus lasers versus chemical peels, all of it, some of it in what capacity. But when I'm thinking about a true full face assessment, making a diagnosis of aesthetic pathology, I know I've listed a lot of things, but it actually happens pretty quickly because we have a checklist. So I start with that brow position, then look at the forehead, then look at the glabella, then look around the eyes. Then I look at the temples, and I look at the periorbita. Then I look at the midface. How is the midface interplay, the nasolabial fold, submalar hollow, jowl, jawline, ergatrid, nose, lip, mouth, all in the central, chin down to neck, and that's my full face assessment.
Now, we did make one little mistake.
Mm-hmm.
We didn't start out saying something positive. My patient is a psychologist.
Okay.
She wants to go now to a psychiatrist for antidepressants. Okay? So let's never forget how important it is to say beautiful skin tone, excellent nose, no super tip droop. There's some very positive things here which we have to start with so that she doesn't, want to jump off a cliff. And she's 71. Woohoo! Now, she has been my patient for several years.
Well, yeah.
Well, I think, I had a chance for the first time just to meet her backstage, and we kind of were just briefly discussing, and we hadn't done a full face assessment, hadn't talked about all these things, but what I thought was so impressive was your two dynamic, the dynamic between the both of you. And literally, while you were saying, okay, this is what we're thinking about doing, and what do we think about this, we had a whole list of different, in small tweaks. These sounds like a lot. I usually tell patients, I'll sit in the chair, now you pick my face apart, because it's only fair. But when we're coming up with this plan, you hadn't even finished your sentence, and she goes, whatever she wants to do, I trust her.
See?
And so I said,
that's the magic word.
How long have you guys been working together? And it was your daughter-in-law that was her patient that kindly suggested you go visit her socially, of course. Daughter-in-law, yes.
She doesn't even live in my town.
And they've been working together for 3 years now. And here we are in front of all these strangers, and all she had to say was, I trust you. And that is saying a lot. But I trust you. Do whatever you want. You didn't even finish telling her what the plan is, and she's like, whatever you think, I'm okay with it. And I think that says a lot about the bond and the relationship that you form, and she knows that you're going to do right by her and have her looking great.
And the other thing she said, because she plans on going to work, is on Monday, I don't want to look weird, right? That's what she said. I just want to look like me. I don't want to look weird. And so keep that in mind. We don't want to send anybody out who looks weird or doesn't feel comfortable with who they are. Now, in starting out, I don't know if any of you use Technicare. This is a chloroxylenol as opposed to Hibiclens. Hibiclens is toxic to the eyes and ears. This is not. People don't react to it. It is. I own no stock in this, unfortunately. 1-800-325-9681. Surgical scrub. It's excellent. It's not like betadine, not nasty color, but it actually doesn't irritate the skin, doesn't smell. It's a little bit slippery, so sometimes after we use this for prepping, we'll even use a little alcohol to degrease. Mm-hmm. But we find that this is for Mohs and for procedures on the face, this is our best. We're putting implants in people. And we're implanting people in a deeper, more avascular plane than we used to. Especially like when we do bolus injections over the zygoma. You need to treat it more like a surgical procedure. You've got to prep the skin. Alcohol, you're kidding yourself. It's bacteriostatic. It is not bactericidal. So when you think you prep the skin with alcohol, I don't think you did the job I think that you need to have one of these bacteriostatic type agents. That's number one. And what I'm going to do is just come back around where we were kind of touching around here. We don't use ChloraPrep. This is what we use for Mohs and for cosmetics, primarily on the face, around the eyes, and ears. And so I actually find this to be, for me, it was off the market for a while. They had some labeling issues, so we couldn't get it. And then we were so excited, Jean Ann bought it by the gallon. And then you got to wash your own hands, right? So in the morning, I usually wash my hands in the beginning, but all time throughout the day, we use one of these foam antiseptics for our hands. And I do that for surgery and for all my filler patients. Patients want to know you have clean hands. So I like this product. My husband used it at his surgery center. That's where we got it. Okay. So those are two things that we really like. So now, Ms. Pat, you can rest back. Now, I'm not trying to say this is a sterile procedure. This is a clean procedure. And the company recommends using sterile gloves, which I put on because that's the way the company wants us to teach it. But quite honestly, even when I know this is going to hurt your ears. Even when I do my Mohs surgery, taking the sections and doing the closures, I use clean gloves. Ron Whelan showed us it did not increase the infection rate one iota. The gloves primarily are to protect you.
Sure.
Right. So that's why we wear gloves, is to protect us. Anyway,
Can we pan down a little bit on our camera?
Where I'm at on gloves and what we do. Now, often when I'm doing live injections on the podium, I'll do them with sterile gloves. That's only because they fit my little bitty hands better. It's hard to find clean gloves that fit as well as a sterile glove. Okay. Now,
Great.
How many people
Thank
here
you.
have done an Instalift? No? Okay. So let me tell you about this. It is not a facelift. You cannot have patient expectations it's a facelift. It is tissue repositioning and some revolumization because it has polylactic acid cones on it. It comes with 8 cones, 12 cones, and 16 cones. I think the 8 cone is really the workhorse of what we use. It is, I think, durable for about a year. There was a webinar Thursday night. My dear colleague in Chicago, Julius Few, he thinks it lasts for 2 years. I don't know. Maybe he's doing it better than I am. But in our patient population, we find, and we tell them for expectation, 12 to 18 months. We also, oftentimes, when we have mid-face, it's actually approved for mid-face lifting. Clearly, our patient here doesn't need that. When we start this procedure after prepping, with the patient sitting up, I march her, and I've already anesthetized the entry point and the exit point. Very importantly, there's no need to anesthetize, and you do not want to anesthetize the point between entry and exit. Because the patient will tell you if you're in the wrong plane, because it hurts. If you're too deep, you're down toward the muscle, there are more nerve endings, it hurts. If you're too superficial, they'll tell you in the dermis, it hurts. That's where the nerves are. So intentionally, we do not anesthetize entry and exit points. Now, move to this side just a bit.
While she's positioning her patient, I think it's so important to understand, what these different sutures are, right, in the world, because every few years there's a different type of thread lift, so to speak, that seems like it comes on market and in vogue. Whereas here,
no, you won't feel this because
and you can maybe talk. She's just using a port. Is that correct?
This is an introducer.
Okay, an introducer. Yeah. What size?
This is an 18 gauge.
Okay.
And what I'm going to do is I'm just going to kind of spin it a little bit because it's a 23 gauge needle that I'm going to advance the suture with, but the cone is a little bit bigger. And so if you'll just stretch this, and notice I just really need to pop through the dermis.
Right.
Because the plane of advancing the 23 gauge needle is in the subcutaneous plane. Correct. So here I'm just going to stretch that skin.
So while she's creating those sites with her 18-gauge needle, you can see literally when she popped right and broke through the dermis, you can see that just nice little pop, very little resistance now, and she's just giving a little twist to help create enough of a track for her to pass her introducer needles in through. This is poly-L-lactic acid, so it's basically like what we're accustomed to earlier, which is Sculptra, but this, of course, is a solid form. And these are basically these cones that will help catch through the dermis.
I don't know if you can see those cones. See right there? They're little cones. And when it comes out of the package, the little knots in between the cones are not set. So you literally have to pull. Now, you don't pull from the ends. It's a bidirectional suture. You don't pull from down here because you can pull it off.
Could you maybe just lower a bit? There we go. Perfect. Just so we could see it.
I don't know if you can see that. Can you see
It's a little hard to catch. We can see that there's texturing along the cone.
So you pull it like this so that you set the knots, all right? And then I'll often take the needle that I'm not using and anchor it down here. Then I'm going to take this, and on this is a 12 centimeter 23 gauge needle that has a little mark right here that tells you how far down you need to go into the skin before turning it to advance it. So I'm just going to take it right here. And this is sort of like you play golf and then you play the violin. The golf part, you come and you just slide along till you pop in the hole. All right? And then I'm down past. I don't turn until I'm down, and then I put my hand on top of the needle so that I can just advance it, turn just a bit. And then this is the cap to the 18-gauge needle, which is going to be the catcher.
Okay. So
okay, sorry. How's that?
There we go.
Turn just a bit. See that? And so then I make sure that I'm in a nice even plane. If I saw any dimpling here, if I'd come too superficial and I'd caught any of the dermis here, I simply slide the needle out, replace the needle again. So you can see that I have a nice even plane, and I'm just going to pull this right out, just like this. And now, as I pull the cones through, I'm going to make sure that I pull counter traction, and I don't pull from the end of this of this suture. I pull very close. And then I get to that part where there are no cones in the middle, and I'm going to then advance medially with the second needle. So it's bidirectional. We've learned not to cut this posterior needle off until we set it, because that suture and her hair look exactly alike. And sometimes you lose it. And then Gina and I are looking at each other. We know that is around here somewhere. But this way we hold it in place. All right, so then I'm going to place the other one. Now turn upward just a little bit.
So now I think one of the technical things that she said that's really important is that when you are setting your tension, you don't pull on the needle, because the weakest point is the interface between the suture and the needle, so you don't want that to pop off. So she's pulling on the suture itself. And you can see that she's working her way through. It glides very easily because she's deep to the dermis. She's in that superficie. She's in the SMAS. She's not feeling, the patient is quite comfortable. She has not anesthetized along that entire vector.
Okay? Mm-hmm.
So
she's great. Mm-hmm. See, we don't paint them, you will retain them. So I watched my daughter. I was teaching the residents at the University of South Florida last weekend. They were at my office, and I watched my daughter do this. And she informed me she is more ambidextrous than I am. She can do it left-handed and right-handed. I actually find that I'm much better with just my right hand, but she can advance them either way. I said, well, it's okay. All the what works.
So, okay. Susan, right now you've just placed it, but you're not setting any tension until
right.
you get this next.
I'm not setting the cones. Okay. I like to place all of my sutures in before I set my cones.
There we go. So that is a great angle to be able to show. So we can see how she's just tunneling. She's staying deep to the dermis, so you don't see anything tenting. She's got her device at the end to just help her set the tension. And the only place, again, that she injected a little bit of local is at those small little entrance and exit sites. She's pulling her cones through which over the next several weeks will start to eventually sort of be absorbed by the body, leaving behind basically a little bit that neocollagen formation because of the way lactic acid is. And again, you can see how nicely she glides right through deep to this dermis, and then we go from there. And now she's pulling out, no dimpling. Really important that you recognize that she's going through the same hole, so there's not any dimpling in through there. And again, minimal bruising or anything like that.
Now, sometimes even immediately after you do it, you'll see a little bit of dimpling because there was a wheel of local anesthetic there.
Sure.
And so I've literally put a donut hole right in the middle of that anesthesia with this. And sometimes if you come out and there is bleeding, then you just hold a little pressure. You want to make sure that you don't get in a rush, you don't hurry through the procedure. And again, if we see too much bleeding, then we'll have a little aluminum chloride on the tray because dermatologists always have aluminum chloride in the room. You can put a little bit of that on there if she sees that she's going to have a little bleeding or bruising. Okay. Now, the other thing is you notice, Jean Ann and I learned that, now slide to this side, please, Pat. Come. I'm not your biggest doctor you ever found. Okay, here we go. So we found that if you make both, the fewer moves you make, the more efficient you are. So we used to make one entry point, put the needle down, put in a suture, one entry point. We found that we can actually make both entry points.
Susan, is there a way to maybe, without it compromising, I think we could get her rotated a bit, a little bit angled. That would be great for our folks.
How's that?
It's better.
More?
If it's possible, more.
Okay.
That would be
Pat,
much
a little
better.
bit over. Okay, how's that?
Good.
Okay.
So again, we're using our 18 gauge to port. What would also be great after we do this, maybe and the patient's sat up, is we could talk about how you chose your entrance and exit port sites. This, how you decided to set. What anatomically drove you to place those points at that part? Because I think we saw, with your experience, that it's pretty straightforward when in the right plane, technically, which is good. You're making it look easy. But if you could maybe tell us a little bit about your markings, that would be great.
We have found over the last 3 years that we've been doing this, that you get your best vectoring if you are perpendicular to what you're trying to lift. So if here's my point of concern, then I want to be perpendicular. Sometimes I can take a vector and come up and go this direction as another possibility, but you want to be always perpendicular to the area that you're lifting. Gauze for that, please.
I think one of the things that she mentioned earlier, which is so important about this procedure, is this is not a facelift, right? Patient selection is, again, very important, because if you do this on somebody that has a really heavy jowl, neckline, full face, first of all, remember, you're going to get some volumization from the threads. At the end of the day, it's meant to also be a neocollagen formation. So you can, based on where you put this and how many of the different sutures you use, you're going to get volumization along that vector. So you have to be careful about where you're placing it. The second thing also is, at the end of the day, you can't have so much skin bunch that it sits in front of their tragus, and all of a sudden now they're walking around with this tightly, broad, lifted skin, soft tissue skin envelope with just tons of bunching in front of their ear or behind their neck. So patient selection is very important for this treatment.
Oh, I got to tell my daughter I did it left-handed.
There you go, perfect.
Okay. There we go. Well, in my office, when I'm in my electric table, I can always put it down, and then I can work from the head of the bed. Obviously, I can't work around that. So one has to be adaptable. Okay. I think that, again, that makes a point of when you have that electric table, the patient can be reclined, and then I can easily work from the head of the bed, and I find that much more comfortable.
And what also Susan had mentioned was the number of cones that are on each one of these threads, because they aren't a standardized they are a standardized number, but there's not a one treatment fits all. But as she mentioned, her workhorse, Susan, again, are you doing a 6 or a 3? I mean, a 6 or an 8?
No, these are 8.
These are 8s.
So I want to point out, this is a really important thing. The biggest problem people have and biggest mistake they make is when advancing this needle, they try to do it from underneath. And you can't keep an even plane. You have to play a violin. And look how it just slides right along. Because I'm not pushing it up or down, I'm able, with my hand on top, to just play like I was playing a violin. Of course, I can't play the violin, but I can advance these. And I do think that initially, when you look at this, it's a little intimidating, but you'll see that it really comes along quite easily.
And those number of cones basically mean, if I say 8 cone, that means there's 4 on each side of the gap. So there's 4 that are distal, and then there's 4 that are proximal with a little bit of space in between, and then they'll lock into position. So again, anything less than that is going to be for a very small area. I think the 8 is the workhorse typically. Anything more than that is a lot of surface area that you're trying to cover. So I think that really, the lion's share of these, that when we've spoken to colleagues who are doing a lot of these, is that they're typically saying that 8 cone is more than 95% of their patients. So when you're starting to do this treatment in your office, it's really important to consider using kind of the standard to correct enough surface area.
Now, Julius is actually using these in conjunction with a facelift. I'm not sure I quite get that, but he does. And he's also put them in arms and legs. That's a little different. He uses the 16 cone in the knees and puts them in the arms.
Yes.
So, Susan, do you have that little ruler that comes with it?
Yes. Do we have it? Or
I've pulled the cones out the ends a couple times, so you really want to know how long your cones are.
that's a good point. I pulled the cones out too. The most important thing is if you see now as I'm setting them, that we do have a ruler. 0 at the entry point, and then you have to be at least 4.5 to 5 centimeters from the entry point to minimize the number of cones that you pull out. It's very important that you not leave a cone or a knot in the dermis at your exit points. So you want to make sure that you'll see when we cut off this suture that we're going to retract it so that it pops back in, because that's where you'll find a little issue a little granuloma problem Now what I'm going to do is now I'm going to set these cones, and you can actually hear a little pop. You okay? Okay, good. She's great. Here we go. And actually right here, just as you said, David, here's a little cone that just popped out. And so that's not a disaster. You just would want to not leave it in the skin edge. And I tell her she may have a little fullness here, but it all settles in quite nicely. I can feel these little cones engaging into the retaining ligaments. And you want to not pull up. Guaranteed. You pull up, you will snap that suture. It's not the end of the world. But you want to pull in the line of the suture. And if you've gotten a little bit too much purchase, as Julia says, if you get too much, you can always just relax it back. If it's a little too much than what you really wanted, there we go. Now let me come around and set the other cones.
So I think it's a very good question. The question was that what do we expect out of this treatment in a few years, or what are we creating issues or problems in this capacity? So, historically with a lot of the threads, depending on what they're made, a lot of them are polydiaxone. They're the PDO or PDS type of suture, and they sort of fester for a long period of time, and they were often placed in the erroneous plane, and they caused a tremendous amount of inflammation and scarification. And so all of a sudden you go back into a treatment, into a plane like this, and you end up finding that there's a lot more scarring than you would expect, considering the person's never had a facelift. So they come in wanting to have a primary facelift. They think it's a virginal plane, but they've got tons of fibrosis and scarification underneath there. And often, because these sutures are placed, quote unquote, blindly, so to speak, you're not always in the right plane. So now you're creating a false sense of security or a false plane, and so you're having to work through it. So they used to create a lot of issues and a lot of problems. I don't know what the long-term data will show us on these, so it's hard for me to make that assessment. What I can tell you is, again, because this works in a similar mechanism and is the same composition, just in a different formulation of basically Sculptra, for example, we're getting neocollagen formation. There is histology data that's pending, but it's showing, healthier forms of collagen to be formed as opposed, like what we would expect again with Sculptra, as opposed to just flat out scar tissue. So I think in the grand scheme of things, the company certainly is trying to distance themselves from the traditional thread lifts that have gotten a bad name. And
Contour threads.
Right, exactly.
They were only on the market for 2 years.
Right. And a lot of, certain things, there were issues with those. So I think what we're finding here, at least so far from the European days, we're not finding or seeing the same elements of complications, scarification, and fibrosis that was seen with the previous generation of these types of treatments. Which is why these are sutures. They're a different type of treatment.
Now, I will say that someone who's had a facelift, contrarily looking at from the other side of the fence, someone's had a facelift and then they come back 10 years later. Nothing lasts forever, right?
Of course, yeah.
They come back 10 years later and they want to have the suture lift as a little pick-me-up. I find going through that previously elevated flap, there is a lot of fibrosis and it doesn't go nearly as easily as what I just did. It doesn't slide through. Now here, this is what Dr. Applebaum was referring to. This is what I did in the back. Here is a 0 point right in the middle. So you have to make sure your exit point optimally is around 5 centimeters from the entry point and then 5 centimeters posteriorly. And so you put this down, you mark where you want your exit point, and I just put little markings so that I could know where I was headed.
Our formulation that we have here, we have the benefit of some of the issues they've had abroad with these. So these are not 100% PLLA. They are mixed with PGA also to
15%.
help. Exactly. So
but
15%.
in Europe, they're all PLLA.
Correct, exactly.
It's a different product in Europe.
Right.
It's 100% PLLA, and here it's PLA and PLGA. And before I go on, I want to just point out, when I'm cutting these sutures, I hope you can see this close enough. Turn just a little to the side. I want you to see that I'm going to kind of retract the skin and let it pop in. And that way I make sure that I don't leave a little cone or one of the knots right in the dermis. And so then I'm going to do the same here. Let it pop in. We've left these on here. And we do protect the sharps. We're careful to get them out of our way so we don't stick each other.
But while she's training us, so the difference, is a little bit in the composition, like she said, about 15%. So that's to help with more tension and make it a little bit structurally sound. So I think there could be all those elements factor in, but I think what you're hearing is that this definitely seems like an evolved version of what used to cause a lot of issues. And Sheila, as you mentioned, thank you for bringing that up. What is the long-term ramification or issue with this? And so far, it doesn't seem to be the same types of issues that historically have been associated with these types of treatments.
Okay, so we did that part. And then we talked about that we want to do some volumization in certain areas. And the nice thing is you can do this all at one time. This can be all one day. Now slide to this side again.
Do you think maybe we could, if she's okay and comfortable, we could sit her
sit
up?
up?
Yeah, let's sit up
Okay.
and take a peek and just
okay?
sort of look at where some of this, what we would expect on immediate after when we send her.
And that's only 2 on each side.
Correct,
Yeah,
right.
we don't need these now. You're right. Okay?
Right. Realistically, some people are putting 3 or 4 on each side. Is that correct
Yes.
also?
I often do 3 or 4. My go-to is usually 3, but we're doing more and more. Paul Lorenk in New York is now doing like 5 or 6. I think that she didn't need any mid-face. And truthfully, you can only watch so much of this. It gets a little boring. So I thought that probably 2 on each side addressing this lower face area was most important. And now I think we're going to come and address up here on her zygoma and then that submalar area. So back you go. You okay?
I'm great.
Always touch base with your patient. Make sure, like, how are you doing? We do talk aesthesia. We talk back and forth. If you're not a talker, obviously not my problem. If you're not a talker, then get somebody in your office who's next to you who is. Because it's really very good for distraction and engaging. Plus, we have the music on. I always like the music because it's really, again, subliminal but very relaxing. This is velour. Okay, but I'd like Voluma first, please, because I'm going to start higher. Do you agree? So we're going to start with Voluma up high. I would like to point out, we were talking about ergonomics earlier. Look at this syringe. It's different. It's new. This is a Voluma syringe. I find it fits very nicely, snugly in my hand.
Mm-hmm.
It's kind of rubbery.
I've liked the broader flat part too. It's wider for the base for your thumb. So if you're going to place it like how you're pushing, or if you push
But
with
now
your thumb.
I actually
like
push
it.
like this.
Mhm.
Let's see if I can keep your eyes closed. See this? I push and palm it until I get to the very end. Two things. Number one, you might consider giving this a try. Not only to protect my own thumb joint, which is tired, this actually lets you have more control. You have more control here than you do here. Because the distance it's moving, this is really gives you more control. I learned this from Kimberly Butterwick, who's a dermatologist in San Diego, and she does a lot of liposuction. And so she likes to hold the instruments in her hand like this and palm it. So I'd suggest you consider giving this a try. Initially, it doesn't feel just like everything else. When you hold the scissors in your fourth finger,
Sure.
you know, Captain Kangaroo told us to hold them in our third finger. You didn't know about Captain Kangaroo. But
I did not, but I was going to smile and agree just to.
But I think that if you practice this, it will become quite comfortable and second nature. And then as I get toward the end of the syringe, I actually do have to switch to my tip of my thumb here. The other thing is, with Voluma, I never put more than about 0.2 cc's in it each injection point.
Mm-hmm.
Okay? So now I'm working along here, and I'm doing, this is a little twitch, just for a little distraction.
And what depth are you right now? Are you?
I was down on the bone.
Down on the bone.
And then I gave
okay.
a little retrograde.
Okay.
So that I tapped the periosteum, which does hurt a little bit.
Mm-hmm.
And then I just gave a nice slow retrograde 0.2 cc injection.
And I like the fact now that we're starting here, we'll probably see some more elevation and offloading of the soft tissue from below once we start to get our lift. And again, here we know that there are some HAs that have a higher G prime, of course, than Voluma. Within the Vicross family and within Juvederm, it is the highest G primer lifting capacity HA filler. And she's kind of working her way, it looks like, right along the zygoma as we think about our mid-face injection. And when she comes around to the other side, we may channel Lucy in a minute and just do a little anatomic review while we're working there.
Chin down just a little bit. I just want you to, okay. Now, let's have you sit up for just a sec, if you don't mind, if the camera can follow us. See this? So if I was drawing, we could draw Hinderer's lines, and so then we could see exactly the point of maximum projection. And sometimes you actually have to come around to the head of the bed, or the tail, and come around and actually visualize. And what's happening as we're giving a little extra volume here, this is becoming even more prominent, right? So we know that as I start here and accentuate this prominence, that I clearly am going to have to have negotiated ahead of time in our treatment plan that we're going to need some filler and product in that location. Okay, back we go. Okay.
And
Is
Susan,
this the technique what would you use?
Could we maybe, is there any way to just maybe have her rotate a little bit away from you? Is that possible? Just so we can see kind of where, there we go, perfect, if that's okay with you.
Yeah.
Wonderful.
Is this a technique, do you like this sort of, I call it the KISS technique?
Yeah, I'm a big fan of it, especially as we get more medial. Laterally, because the skin and the soft tissue is so much thinner over the zygoma, I'm bigger on just placing these smaller 0.05 or 0.1 aliquots right onto the bone itself. But as I get more medial and I start getting more central, there's more soft tissue. I like to inject onto the bone and then do, just like you said, kind of Hershey Kiss type technique. We put a small depot of 0.15 and then retrograde, go ahead and drop almost like a little column, 0.05 more or 0.1 on the way out.
And I tell the patient as we're going along here, it's so much fun, it's like I'm a sculptor. Mm-hmm. And at the end of the day, I'm like, they paid me to do this? It was so much fun. Because it's really it's that left brain part of you that is really the creative, interesting. So now, chin down just a little bit.
So how much have we injected so far?
That was 1 syringe of Voluma.
Okay, great.
So she's had 4 sutures and 1 syringe.
If it's not too uncomfortable for her, can we sit her up and see what 1 ml of Voluma plus Instalift looks like on the right side? And remember, her right side was the more deficient side. Remember, so we've started on the slightly more challenging side, And I think we're starting to see how much more kind of within that OG curve, how it's starting to frame the face. I'm not going to touch it because I don't want to, contaminate your field here, so to speak. But we can start to look and see how we're starting to really shape the face and bring what was a lot of loss of volume, almost a little bit more of a rectangular
Could I
square,
have the lift?
back now into a little bit of that nice
now take it.
inverted triangle where her bimalar width exceeds the bigonial width, and we start to just funnel in. So with 1 ml there so far, really starting to frame the face.
I'm actually going to give her just a bit of gonial angle definition. This happens to be Restylane Lift. And so what I'm going to do, I always like to make sure I prime the needle. See that? And then I'm going to, here's her gonial angle. So then I'm just going to come in now a little teeny ouch.
And what are we using here?
This is a little Restylane Lift.
Okay. So of all the HAs, it's arguably one of the highest, if not the highest, G prime. So we're getting a lot of truly sort of lifting and volumizing capacity there. It's still soft. It's well cross-linked as part of what we call the NASHA technology. NASHA is different than the expression technology within that family of Restylane fillers. We can just talk about the difference between the two. And what plane are you on? Are you...
I actually went, well, we know the tail of the parotid comes here.
Correct.
Right?
Mm-hmm.
So I didn't actually go all the way down to bone.
Okay.
Yeah, it'd be nice, and we'll look at that anatomy, but
Yep.
I want you to see that I just came not all the way down to bone. Right here, I was almost close to the bone. And the reason I like to do this is you think Angelina Jolie is beautiful because of her lips, right? No. I have to tell you, the reason she can carry those lips is that big jaw and that very sharply well-defined jawline. So that's why I think in many of our patients, we begin to get a blunting of this gonial angle here. And so by just a little accentuation, we don't want to make it too broad because we've just worked to try to broaden this diameter.
Correct.
But we just gave a little extra definition there.
Mm-hmm.
Okay. Now I'm coming just close to the anagonial angle, but I'm not going too deep because I know at the anagonial angle.
Can we just rotate her just a
Sorry,
touch again?
I keep
No,
pulling her
it's
back.
totally fine. I appreciate. I know that you're pulling a little bit of a Cirque du Soleil act here and twisting and contorting to get to it, but it's coming together really nicely. So you saw that, near the antegonial notch, remember that facial artery, facial vein, marginal mandibular nerve. So she doesn't want to go right onto bone there. We're just kind of filling that in nicely, just camouflaging and working around a bit of that jowl area. And
she has a little bit of swelling here, which I think is even accentuating that even more. But you're right, this is kind of, so then I'm going to come right here now, little ouch.
And now she's working right through the pre-jowl sulcus, which is a fixed and tethered point. We have the retaining ligament, or labiomandibular retaining ligament, that goes right in through here. That's one of the fixed points on the face. So she's just working around there to camouflage it.
Now, I'll tell her ahead of time, you're going to have a little bit of bruise here. I do give patients arnica. I'm not 100, there's no data, I think, to tell us how much it really works, but makes me think I'm trying to do something. Mm-hmm. And then after they've done 3 or 4 vials of something and some neuromodulator, I give them the product.
Sure.
That Louisiana concept of lanyap. Patients always like it when you give them something.
That's right.
Okay, I'm liking that. Turn to this side.
So that's starting to come up really nicely. We're starting to camouflage it. I would agree that I think her jowl region is more edema, exactly, from just
swelling.
From right going through there with the trocar earlier.
And then if I could have the velour on a cannula, please, ma'am. But what I'll need first is my introducer needle. Now, I use one entry point at the oral commissure here, and I'd be darned, I don't know why I always get more bruising on the left than the right. I don't know how I angle it wrong, whatever, but I sort of give my introducer here. This is because I'm going to use a 25 gauge cannula, and I'm going to use velour.
Could we, when you get a chance, maybe just rotate her a touch towards us so we can just see the angle?
You want it to come this way?
Perfect.
How's that?
Much better. Thank you.
Okay. How many people here use a cannula for the lips? Oh, okay. We got some takers. I don't always use a cannula for the lips. I frequently use a cannula when I have my many patients on local anesthetics. But I again, I'm going to prime this.
Now, what did you use to port that site?
That
for your
was,
introducer?
this is a 25 gauge cannula. I think it's
Okay.
a 23 gauge needle. See how nicely I was patient, right? That's the hardest part. You got to be patient, let that little entry point, and then I'm just going to come just like this. This is my brain finger, right where I am.
And what plane are you rotating and working your way? It's advancing very nicely. So where are you with your cannula?
I'm actually not very deep. I'm pretty superficial.
So between the mucosa and the
Yeah.
limbic? Yeah?
Yeah.
Okay.
And I'm right at the wet-dry line
Got it. Okay.
in the body of the lip because she's got very small lips.
So I think that's a really important thing to understand is not to necessarily place it at the white roll on her because she's got a lot of lip that's sort of tucked in and tucked away underneath. So if you place it on the white roll, you're going to give them a bit of that, again, duck look or
And then
trout pout.
always keep an eye on your syringe. If you put half the syringe on a quarter of the lip, you're in trouble. Because she said she only could afford to buy one syringe for the lips. So you always have to keep track of where you are. Now, this is the tricky part. I can't always make this work. But sometimes I can actually come and redirect it. Sometimes I have to come out and redirect it. You okay, Pat?
Mm-hmm.
How much should
Okay.
we place along that wet dry on her right side? Right
About
upper?
0.3.
About 0.3, okay. And this is velour, is that correct?
Yes. I happen to actually love velour in the lips. It reminds me of the old collagen days, except it's durable because it's nice and soft. See, I'm in that plane again, that same plane.
Did you get a block prior to that?
No, I don't like lip blocks.
Oh, I wouldn't have to do it with blocks because I feel like people don't like the cannula feeling in their lips.
I tell you what, the reason I don't like a block. I think it changes your anatomy. And so then you can't see where you are in terms of placement with symmetry. So I actually, I can't think of when I ever did a block. I just don't. Do you do lip blocks for that? No.
Really lovely, so let's take a look.
We've also talked about putting a little Vobella or Restylane Silk or something on this upper lip, on the ergotrid to soften that. But she doesn't want big lips. She's not used to that. So this is really nice and soft. And I have used like 0.4 so far. Not very much, only 0.4.
Can we get you to maybe just turn a little bit the other way? Straight. Let's look at her straight on. So maybe towards the right. Perfect right here. And I know that we've got our little port site placement in here, but you can see, again, in a subtle capacity.
Just a little.
Nice, just enough to complement her aesthetic, which I think is nice. And I think Vobella
there
wouldn't
we
have
go.
given her enough, but I think velour is a really nice option. And again, if we think about different products that'll behave similarly, on the lighter side, you could consider some Restylane Refine that might behave like this. Ultra is probably going to give you a little bit too much volume for someone like her, although it's a fine filler for the lips. And then something like Versa can also be used nicely in this capacity. So if you add a little bit more of Lida with Epi to the Versa, you can get it to behave a lot more like this in something thinner.
And can you tell me what Versa would be equivalent to or similar
I think
to?
it falls somewhere in the category of like an Ultra Plus, but not quite as hydrophilic.
It's interesting. You feel it pop into that virtual plane. You just sort of feel it pop into there. And here's my brain finger. And then sometimes I come along, I do a little antigrade, and then a little retrograde. And sometimes people are asymmetrical. That's how the Lord made them. So I won't necessarily put the same amount on both sides. I'm just coming.
I think what's really important is while she's injecting with her right hand, her non-dominant left hand is doing a lot of work. And I think you've got to have one hand help the other. You notice she's using it to almost basically to give her some counter tension so she's not pushing too hard with the cannula. As she's injecting each little aliquot and little small microbolus, she's molding the product right into place the way that she wants it. So I think you always have to remember, and that's probably the surgeon in her coming out, which is a great thing, that each hand's got to really help the other hand, and your non-injecting hand is often as important or even more important than your injecting hand, because right now she's using it to kind of set and place her. Look at how she's just kind of like taking the tissue and kind of just redraping it over her cannula.
Now remember, we want the bulk of the lips to be in the central 2/3, and the lower lip should have 2 tubercles, the upper lip 3 tubercles. And that's another reason why I save a little bit of my product in case I need to accentuate those tubercles. Let's put a needle on that, please, ma'am.
Yes.
Hello. Okay. 2 things. One, it's very difficult to actually see her face. I don't know if there's a way you can prop her head up or something with a pillow so we can actually see where you're injecting, because we're getting a laid back angle. The other thing is, along that jawline, I'd just like to know a little bit more about the depth, the placement of that lift. Earlier you were talking about, using the higher G prime posteriorly before the notch and then in front of the notch, using more of like a, ultra plus, Restylane, something like that. So what determined using the lift all along that jawline, and kind of where was that being placed? It wasn't on the bone, correct?
Right. I think as she got towards great question. So she got more anteriorly along the antegonial and was in that prejowl sulcus. She was basically hubbed and pretty much right onto the bone, onto that retaining ligament, like I was mentioning. And I think posteriorly, conceivably, she could have gone onto the bone pretty safely, depending on what you're trying to create. Are you trying to create some more bigonial width? Are you trying to create some more length? So either way, back here, you can typically be onto the anterior surface of the bone and be okay. The facial vein and facial artery and the marginal mandibular nerve are going to hug right along the inferior border of the mandible while it makes, and I'll show you that on Lucy in a minute because that'll be a nice demonstration, and then it crosses at the antegonial notch. So I think very importantly, you can still use something high G prime as long as you're on the deep sub-Q part of it. You've got the masseter there, so maybe some of that's even a little bit intramuscular. It's not the end of the world in that capacity. It's HA. But I think you've got masseter, you've got tail of the parotid. So you have a lot of sort of hardy soft tissue structures that are going to camouflage in that area. So even if you're not injecting right down onto bone, it's going to be okay. But anteriorly, she had a deep a deep pre-jowl sulcus, and so she took the liberty of using the product that she already had in her hands to use the rest of it to be economical with it, and that's okay on that pre-jowl sulcus, especially because of how deep hers was. If you had the freedom and flexibility to pick something a little bit lighter, you easily could have, and that would have been okay.
So now I'm using velour.
Mm-hmm. And we talked about that submalar hollow that was more pronounced on that side. So I think, again, you're staying within that family, which is fine and looks good. And you're just kind of working diffusely in through here and doing some needle work to kind of bolster that. This is kind of a
push-ahead technique so that you can actually get even a little more distance with that. But I would like to – that is a very good question. In terms of how deep, I think you can actually go through and go down all the way to the bone here at the gonial angle. I'm just very careful as I come to the antegonial notch to be cognizant of what's underneath it.
Sure.
See, look at I gave her a little tweak to her lips, just a little bit at her cupid's peak.
So when we're looking at her now, I mean, I'm looking at her from there, and I'm looking at her straight in front without wanting to occlude our view here. I mean, I'm seeing a tremendous amount of improvement. First of all, we're seeing this was the more challenging side, so to speak, and now you've really focused on kind of helping volumize this area that was very drawn in. She's starting to show some nice fullness in an appropriate way and reinforcing her zygoma in through this area, which she actually has an OG curve now, which she didn't have before, so that's looking nice. She's probably someone who could maybe do a little bit more centrally in the central fullness because she is still a little bit flat when I'm looking at her laterally. Right. But we are really off to a great start. Nice continuity and cleaned up through that submalar hollow. We're not seeing any sort of flattening out here laterally anymore, and that has to do with volume resuspension here that you already pulled her up. So that's now helping that area redrape. Lips are looking lovely on her, and then it just starts to lead into doing more.
It's just enough lip to be like, my mom would say, a suggestion without making her feel self-conscious about her lips. That's not to say 2 or 3 weeks from now, she can drive back over and say, I really like these, but I want MOA.
Right. Well,
and sometimes that happens.
Right. Absolutely. And I think one thing that would be nice is right now through this angle, we can see that without having done anything on her mid-face, and this was the slightly fuller side 30 minutes ago, we see how much flattening she has. And when we start to just rotate her here, we can see that we're actually starting to create some nice volumetric changes laterally here. And like we said, just at least give her some OG curve, but a little bit of flattening here. But you look at the difference there. This was the flatter of the two sides, and you bring that over, and I'm just going to just rotate you a bit more, please. Perfect. Now you can see how she's still kind of deficient on that side. So we're starting to see
and the
subtle
beauty
changes.
of that cannula here is, I think it's less traumatic. There's less swelling in the lips, less bruising. So if someone just needs wet dry, they don't need like a lot of fine detail. If I really have to do a lot of fine work, I just did my daughter's lips. I did them with a needle. She just needed a little bit. I did some Vobella. But if you use these and you just want volume at the wet dry line for overall some lip enhancement, I think that cannula is just so gentle and nice. Now, sometimes, I will tell you, I put a tiny drop of anesthetic at the oral commissure just so she didn't feel my introducer. But overall, I think that was pretty painless and pretty soft and gentle. Okay, back we go. And how are you?
I'm great.
She's great. And so she's had 3 syringes and 2 sutures, and she's great.
Before we take this question from Dr. Applebaum, let's give our patient a round of applause for being so great. Thank you. Perfect. Yes,
So
I'll come to the other side.
a couple quick questions. In the submalar area where she was putting the velour, I think it's a great product in the area, and I actually blend it with some saline because I don't think it gives the bulk and fullness that you see at the other products. So when you got in each of your minds, what products should you not use in this area, and which products do you think are safe or reasonable to do? Because the problem with velour, it's a more expensive product
Sure.
But it
compared to
lasts
some of the other
longer.
ones.
Right, and I think we get some more longevity, so I think we can sort of justify that component of it. I think what I wouldn't use in that area is going to be HA or non-HA, just across the board. I'm not going to use Belafil. I'm not going to use Radiesse. I'm not going to probably use Voluma, and I'm not going to use Lift. Those are 4 things that I know that I probably, or maybe did I list 5, that I will not be using because of the nature of what their G prime is like, and also the fact that some of them are larger particle size, and I'm really looking for something that's a little bit more of a blending sophisticated, or a little bit more of a refined filler rather, not sophisticated. That's just going to help me get that contour so I can have the volumization I want in the mid-face, and then a smoother transition as I start working my way down. So what is going to be good here is really, again, like I said earlier, I think Ultra can be a great option here. Velour can be a great option here. Refine is a great option here. I think Bello is going to be a little anemic, so to speak, so I don't think that's going to work well for me here, and I don't think Silk's going to do a good job here. But I do think that other family, those are going to do quite well. And Versa, I think, also can give us some nice volumization there.
But I do agree with you, Dr. Applebaum. This submalar area, it is kind of a sinkhole.
Mm-hmm.
I mean, and that, quite honestly, is why in the Voluma study for FDA approval, the average patient got 6.8 syringes, because remember, they were also treating submalar defects here. And that area can just like a sponge, kind of just suck it up. And so this is a more expensive product, the velour. And you have to let that patient know. I do feel like in my hands, I can sculpt better with it than I could the older Juvederms, but you have to make sure it's in the budget.
I think Sculptra could also be a very good addition in this area for sure. And if I didn't mention it, that was my fault. But yeah, I like Sculptra in this area as well. Just making sure the patient's not an immediate gratification type of patient where they're getting volumization, mid-phase volumization here, and now you tell them to wait a few months and we'll do another one there versus if they want the immediate gratification, which you're nodding and smiling, so I think you're probably echoing that. What we're trying to replace in this area, just for anatomically, remember to correlate, we're looking at the medial superficial fat pad, right? That's what we're trying to do here, is really help kind of revolumize that area when we were in the mid-face. If we peel the superficial layer back, so this was I'm going to go back for a second. Remember, this is where we were passing our Insta-Lift through. This is going through deep to the dermis. We peeled that dermis back, and now we're looking at SMAS and this healthy yellow fat. This is where we're passing this nice, clean plane. We don't have a lot of resistance through here, minimal sensory innervation through here. Patient didn't have any discomfort just once we pierced through the dermis. So this is that plane. And again, we're looking at those fat pads, which I just mentioned. We've worked on volumizing and has had a discussion about those medial superficial fat pad for that submalar hollow in particular. And then once we really start to scale back now, this is obviously the deeper component, but thinking about the zygoma meeting the maxilla, and as we kind of trace it back. So this is what we're placing on the bone, is where we want to be placing our lift or our voluma when we're placing that's on supraperiosteal injection. And if we peel all these muscle layers back even a touch more, now we're really looking at some very deep fat pads, and this is not what we're trying to treat right now, just so you know, though, to orient you. And then let's go to the jawline, just in terms, again, of looking at some of that important anatomy there. So on our fat pads, we remember that jowl component. Let me just get to the superior jowl fat pads. We're peeling that layer back. Again, along the jawline was where she was placing one of her inferior threads. And we can look through this area, and I'd like to point out our facial artery and facial vein. I'm going to just zoom in here. So again, as we track this back, thinking about kind of where and how it falls, I'm just trying to get a little bit more posterior for us here. You can see that it loops around the taloparod inferior portion of the mandible, and then it goes with that antagonal notch, traveling with the marginal mandibular nerve. Now you can really see how it courses, and remember the nerve, artery, and vein travel very closely together and are very nicely oriented while they loop around to the inferior border of the mandible. So again, to our question in the back for our colleague that mentioned the question about placing this on the bone, again, you can safely place this on the bone, but understand you are going to go through some other soft tissue and important structures. Patients may swallow a little bit more when you pierce that masseter fascia. That's going to hurt a little bit, right? The innervation to skeletal muscle for sensory goes through the fascia. If I do a submuscular breast augmentation, when I cut that pec fascia, that's when the patient has a little bit more discomfort than if it's a pure subglandular. So anytime we violate skeletal muscle in the fascia, even if it's poking through to inject our Botox, you know you're in the right place, or a neuromodulator, because you're piercing that fascia, and they're going to give you real-time feedback that hurts a little bit. But at least you know that you're typically in the right place. So it's kind of what I wanted to show us with respect to anatomy. I think it gives us an overview of what we were doing in this area in particular. If we want to cut back to Dr. Winkle injecting, that'd be great, and then we'll wrap with this patient and take our break. To answer your question while you're injecting, I have seen some of these nodules with Vicross. I think there's a few different reasons why they are occurring. I'm always open to discussion about it. You mentioned earlier something really important, which I don't feel like I always hear a lot of people say, which I firmly believe in, that is that at the end of the day, we are placing implants, right? These are in place of what we used to do, which is placing implants in the face. We had jawline implants, we have chin implants, we have malar implants, we had all these different facial implants of different structures. We have lip implants, right? Gore-Tex grafts. All the more reason why I think it's an important component. Make sure that we're very mindful when we're injecting. You know, this frontal, the patient, our colleague who earlier had that patient with the frontal plate, the titanium mesh plate, that's a bit of a one-off, right? That's something we have to be mindful of. But still, we see a lot of patients have chin implants. We've had rhinoplasty. They're now back. Be careful that you're not seeding those implants. A thorough history will elicit the fact if this patient has a history of implants. And a lot of those implants aren't necessarily hard implants. We put silicone-type prosthesis in the chin. You could easily pierce that with your 27-gauge needle and load up that implant or seed it and colonize it. So think about what you're injecting and think about previous procedures. Now, with that in mind, I think that it's an important component to understand that when we're using something like Vicross, which I love using, because of its tight cross-linking, because of its longevity, we do have an implant, theoretically, that can persist for up to even a year and a half, 2 years. So if we think about seeding objects with biofilm, not using a sterile technique, using something bacteriostatic like just alcohol to wipe the face and then not letting it even dry, putting on non-sterile gloves, getting our needle, injecting a little in the lip, and taking it to the mid-face, and taking and bouncing around, not changing out needles, I think there's a component where we're putting large aliquots of a biocompatible filler or implant and seeding it into the face. and then wondering when they get a post-viral infection or they get some type of systemic immunocompromise, that all of a sudden when something flares up, acts up, and is irritated and inflamed, start to really blame the product. I think there's culpability on both ends of the spectrum, but one of the things we have to be mindful of is if we want longer-acting fillers, and we want to use these treatments to help volumize and give patients longevity, our technique does need to evolve a bit with it because we know that these fillers last longer than historically what we've had before.
And are harder to erase.
Correct, exactly. Because of that tight cross-linking, they are a little bit more challenging to get rid of, no question. So again, plastic surgery principles tell us when I place an implant, typically the safest and best place to place an implant is under a muscle. It's well vascularized. You've got excellent blood flow to the tissue. It can fight off a little bit of that biofilm if there is one. So I don't think we see as many of these nodules or issues with mid-face voluma, even though it's Vicross, because we're placing it deep to the SMAS, deep to all those lip elevators. It's the deepest we could place something, and in the same anatomic plane where we'd be putting a zygomatic implant or a malar implant on the bone, on the periosteum. But all of a sudden we take those same products and thread them superficially through the mid-dermis, and we seed them and place them in here without as much of thought process behind our injection technique. And we never put implants within the dermis in plastic surgery, because we know that although the dermis has good blood flow, it's a very tiny plexus, a subdermal plexus of vasculature that can't fight off necessarily biofilm seeding and an infection. So I think that there are some really important things to think about. I think Vicross, to a certain extent, has gotten a bit of a hit in terms of everyone saying, oh, these Vicross are nodules, nodules, nodules. But how are we using it? Where are we placing it? Are we being good with our appropriate technique? Are we changing needles? Are we wearing sterile gloves? Are we using bactericidal topicals? Are we evolving with the fillers evolving? That's my take and my thought on it.
I couldn't agree more. I think you're exactly right. But I think what's interesting is as a product's on the market longer, we tend to see fewer nodules. Mm-hmm. That's what happened with Voluma. That's what's happening with Volbella. And part of it has to be, it's not always just the filler, it's the filler, the person behind who may be. It's interesting, and I don't think we totally understand it, because those delayed nodules can't be the filler because it was smooth when I put it in, there weren't any problems, and then I come back and it's a problem 3 months later. So I think we're still understanding that. I think that's where we have to put it. Now, I will show you, on many of these syringes, what I've done is I take bevel up, and then I take my finger and just gently bend that needle at an angle. And the reason I do that, especially like when I'm injecting in the glabella, it allows my hand to plane more easily. I learned this from Arnie Klein. Okay. Arnie Klein in Beverly Hills used to come to Stanford in 1980 when we did the collagen studies, and he told us to bend that needle like that, and it served me well ever since. And while we were chatting, I put a little bit of Volbella on the upper lip. I came back and I just put a little Volbella in my white roll, because women hate those little lines that bleed, right? That was a positive. We don't like that. How are you overall?
Right now?
Yeah, are you okay?
I'm fine. You can keep going.
Okay, so we've had Voluma, we've had Velour, we had some sutures, we had Velour, we had Volbella, we had a little Restylane lift. So we've had a variety of things, and my patient couldn't be happier.
Could we sit her up and just take a peek with her head on? And I like that you started to work. You're working on her chin a little bit too, I saw. Is that right?
You know why? Yep. I dropped her Steiner line.
Sure.
And I realized she doesn't have nearly enough projection. So we probably are going to have to come back and over time continual and do some projection and add to that, because if you turn to the side, you can see her lips are really nice projection, nice balance between, but her Steiner line tells me that turn just a wee bit more. She needs a little more chin projection. in order to have balance and harmony of that.
But what I do like, and knowing very well that a lot of this is swelling because it was right in the path, exactly, is I love what we're doing with her mandible, with her angle here, building it a little bit out because it's a little bit atrophic, so we've got this nice amount of lift in through there, and what you camouflage here at the prejaw sulcus. If we turn her the other way, in which you haven't worked on that yet, we can see a bit more how atrophied that portion is and what a little bit of lift did in terms of volumizing that angle of the mandible.
So I think that's really, that is a nice amount of being able to. Now, is every patient going to come in and want this many syringes? Is it realistic? Probably not. It might have to be done in a staged fashion, but this is the kind of thing you can discuss as a whole treatment plan.
Absolutely. Yeah. Great.
I wonder if you could just summarize real quickly your thoughts on current treatment algorithm for nodules, whether they're acute, delayed onset, inflammatory, non-inflammatory, and speak to steroids, steroid injections, antibiotics, that type of thing.
Great question. So in the instances, because, for example, with Allergan, I am the, National Adverse Event Specialist for Kybella. What that's turned into is a lot of calls even about fillers or certain things like that. From an approach and what the patient's been referred, we've seen a couple of patients in my own clinical practice. Interestingly, it's almost always been associated, it has been associated in those 2 or 3 instances with some type of post-systemic infection. They had the flu, they're immunocompromised for just the fact that they were a little down and out, usually on a slightly more mature patient, and sometimes it's been associated with international travel. And I don't know what that all means. The cases have been referred, have been some international patients and some domestic ones. So we've seen a handful of these patients. There's only been one instance where I've actually had to dissolve it, and that was pure and simple because the patient requested that he was going to be traveling abroad for work and didn't want to run into a flare type of issue. We've been able to control each time with basically a Solumedrol dose pack. I don't place the patients on antibiotics because none of them come out with like fluctuance or cellulitis or anything that looked like an infection. It just seemed like something that could be managed as some type of inflammatory process. So we've not had to place patients on broad spectrum or narrow spectrum antibiotics. I've typically done an oral Solumedrol dose pack. We haven't had to inject anything, and in one case, we've gone to the extent of going on with Hylenex and hyaluronidase and dissolving it because the patient had just concerns and for peace of mind wanted it to be dissolved in the prejaw sulcus, where it was a very superficial, palpable little nodule that did get better after a 1-week course or a course of a Medrol dose pack. I know that there's talk of antihistamines in place as well to help decrease inflammation. It's been pretty simple and straightforward. I've started with a Medrol dose pack, and it's resolved to the point where then I give them what I call a filler holiday. So I ask them that they will not be getting any fillers for typically 4 to 6 months. That's completely anecdotal. I don't have any science to back that plan up, but I just want to give them a break. And I've gone back to using Vicross on that same patient, had follow-up for a year to year and a half with no recurrence.
I actually do put them on an antibiotic.
Okay.
We've had lengthy discussions at the Allergan team, and I put them on the steroid. I put them on usually Biaxin. I put them on that, and I'm not sure whether it works. I know it doesn't hurt them, so I'm not really hurting them. I have seen them improve. I haven't seen any, and I haven't actually had any of my own patients. I've only had patients referred to us that I've treated. I am not a fan of intralesional. I don't mean to ignore this side over here. I'm not a fan of intralesional steroids because I'm always worried that they're going to get that surrounding atrophy and then a nodule that's not even visible. Next thing you know, you've atrophied around it and it becomes visible. So a non-visible nodule to me is more livable than something that looks like a knot. That's one of the reasons. Now, some people talk about 5-FU mixed with intralesional steroids. Again, I try all of these other systemic approaches first, and only as a last resort would I mix a little 5-FU and steroid and try that. But all of them I've seen have resolved.
Same here. So we've not injected anything into the nodule from our practice, and I think you're hearing from Susan as well that it's not something that's part of her typical algorithm, but she would reserve the right if it was a recalcitrant or one that wasn't responding.
I want to say one last quick thing is my injecting. I don't own any stock in this either. This is called cytoactive. You can use either cytoactive, you can use ultrasound gel, you can keep it in the refrigerator, and because then when you take this gel and you can gently mold, and it increases your tactile sense with your glove on, and you can feel if there's any lump or bump, anything I don't like. Some people think it helps with bruising. I'm not sure about that part. But I do think it really lets me feel, and the patients really like it. It's good?
Feels great.
Okay, feels great and lets me feel my product and make sure that I don't have any lumpy bumpies.
That's great. Nice little pearl in terms of that. We do similar thing. We'll use HA5 or something like that as well. That just gives a little remoisturizing. We can also take a feel, so I like that. Perfect. Yes, Sheila.
So she discussed the needle to the bone technique for the posterior jaw. Can you discuss the cannula technique that you would use for filling that posterior?
Absolutely. So the question was talking about cannula. So we've got the needle technique around the bone for cannula itself, and I demonstrated that on that sort of sped up version on that male patient. But I think what we basically end up doing is I look at the length of my cannula and I try to map out proximal and distal to where I am. Can I reach where I need to reach? So I just look right where I need to go so I can get back towards the angle of the mandible and anteriorly. And this is typically to increase definition, not to elongate the face. I love on a patient, I have a little bit of a round face, square faces, different things like that. And if you can elongate, that's going to be a needle technique on the inferior portion of the mandible to actually drop and create some length. But if you're talking about definition, filling it out on some of the patients that I showed examples of, basically I'm mapping out that distance. I go right in half, make sure that my cannula can reach front and back, and I port and I stay just deep to the dermis. I'm in this sub-Q space. It's an easy place. It's a nice plane. You just work right back. And if I need to get all the way back there and can't, I'll just use my non-dominant hand and just kind of like almost thread that tissue right over it and go ahead and get a nice linear thread and start depositing some voluma or lift just in that area. And then I massage it very carefully so I don't end up with, a hyaluronic acid sausage there right along there and just kind of diffuse it. But that's usually what I'll do. Then I'll come out and I've already got my port ready to go, and I use the same hole and head down distally, and I'll do the same thing. Distally, I like to do this if I can just in front of the antegonial notch, because at that point, if I'm using the same product, let's say I've got, extra voluma left, and I know that I don't want to put too much voluma centrally, especially on one of my female patients, I don't want to masculinize them, I can have the ability to dive right onto the bone distally because I know that I'm past my antegonial notch where that facial artery, facial vein, and marginal mandibular nerve have already crossed over. So this is a very safe on-bone injection. So even though I'm using the cannula port site, I'll dive a little bit more, go right onto bone, and sneak right underneath the platysma, going onto that inferior border of the mandible, and just deposit right on the bone. So I can use the same product through the same port with the same cannula, but just go a little bit deeper if I need to with a high G' larger molecule size type of product. And then, if I need to, I'll do a little bit of needle work centrally, but typically this will get me all the way to the menton, which is the central portion of the mandible, and I can do that with one port site and a 25-gauge cannula. That's 45 or 50 millimeters.
One of the reasons I didn't
Does that help?
I didn't use the
Perfect.
cannula here is because I knew I had my suture there, and so I wanted to just do kind of depot injections around my suture, which was placed along the mandibular ridge there. But I frequently do exactly, as Sachin said, I will start here at the gonial angle. I'll either go superiorly and do a little fanning and then come this way along the mandible with it. But I personally, again, I don't know stock in this, I'm just sharing with you, I like the TSK cannula. I've tried all of them. And the reason I like the TSK for me is it's sharp enough, not too sharp. It's not as flexible as some of the cannulas. Did you see how easily and how much control you could have with that cannula in her lips? Because it's a little bit stiffer. I use a 25 gauge 1.5 inch, and sometimes in the hands I'll use a 2 inch. But I would recommend you need to try the soft fill, try the Dermasculpt, try the Magic Needle. All these are varieties of cannulas, and quite honestly, I think we've come a long way with understanding these tools, and they really do give us another wonderful injection technique. Okay?
Wonderful.
Thank you very much.
Great. Thank
Good.
you.
Bye.